Okay, this morning I'm going to be talking about some work that was done as part of a study called FemHealth, which was looking at user fee removal, removing financial barriers to maternal health care in West Africa. And I'm going to talk about that in light of some problems we have with measuring universal health coverage. So as I'm sure everyone in this room is already very well aware, we're now in a new era defined by the Sustainable Development Goals. And target 3.8 is to achieve universal health coverage, which is defined as including financial risk protection, access to quality essential health services, and access to safe, effective, quality and affordable medicines and vaccines. It's worth noting that the words essential and quality both appear twice within that statement. And there's two metrics which are to be used to measure this. The first is coverage of essential health services, and the second is lack of financial protection. And my talk today will focus on the first of these two indicators. So what are essential health services when we're talking about reproductive health, which is the area in which I work? The framework for monitoring is probably going to end up focusing on just coverage of a small number of interventions, which are known as tracer interventions. And a group of influential authors who've been very involved in tracking the progress in the Millennium Development Goals, Countdown to 2015, which has now become Countdown to 2030, have proposed creating this composite indicator in an article which was published in the Bulletin of the WHO last month. And they've proposed three different tracer interventions: demand for family planning, one or more antenatal visits, and skilled birth attendants for measuring reproductive health. Skilled birth attendants is the one of these which focuses specifically on maternal health, and that's defined by the WHO as an accredited health professional, which could be a doctor or a midwife, who's been educated and trained in the skills needed to manage an uncomplicated delivery, so a vaginal delivery without any severe complications. During delivery and in the immediate postnatal period. And also they should be able to identify severe complications and refer them to a higher level facility, should that be necessary. Now, this in itself is important. It's very important that women have access to skilled birth attendants and attendants which is care is respectful. However, for severe complications, which is where most of the morbidity and mortality in maternal health arises, it's unlikely to be sufficient in and of itself. A single birth attendant, no matter how well trained they are, will struggle in a situation where a complication arises, such as a hemorrhage, which is a very time-sensitive, challenging complication to deal with. She's on her own or he's on his own, only one pair of hands. You've got two patients, the mother and the newborn. And generally, to successfully manage most delivery complications, you need access to more sophisticated equipment than a skilled birth attendant on their own can provide. For example, blood transfusions or access to surgical care. So while skilled birth attendants is very important, if we're talking about reducing mortality and morbidity, you need more than that in addition to skilled birth attendants. So how do we measure coverage? Skilled birth attendants is relatively straightforward to measure in a low-income setting. You can ask women through surveys who was the attendant who was with them at delivery. There's a bit of misreporting around that because women tend to overestimate the skill set of their provider, but in general it's conceptually relatively straightforward to measure. For access to life-saving obstetric interventions such as Caesarean, we usually just measure this through a Caesarean rate. And we can measure this either through routine data, because the Caesarean has to take place in a health facility, normally a district-level hospital, or we can ask women in a population-based survey whether they delivered vaginally or via Caesarean section. So it's relatively straightforward to get a proportion for the number of women who had access to this intervention. When it comes to do we have universal health coverage, we have a problem when it comes to the obstetric interventions, because we don't expect everybody to have a Caesarean. That's not a good thing. We neither want nor expect 100%. So what is the percentage which we're trying to get to? What should be our target? how do we know whether what we want is women who need such care to be getting it? But that is difficult to measure. There's concerns in many areas of the world with over-medicalization of delivery care. So you get, within the same metric, kind of different subgroups where some groups have too much intervention, and some groups have unmet need. And disaggregating that is difficult to do, but essential to do if we know whether or not we really are achieving universal health coverage. We have a similar issue within family planning in that we usually measure that through contraceptive prevalence, but we don't expect or want contraceptive prevalence to ever reach 100% because at any one time, some women are trying to get pregnant, other women are not sexually active, and so on. So we use this metric called unmet need for family planning, or its inverse, which is demand for family planning satisfied. However, no equivalent measure exists for caesarean sections. Different groups have tried to come up with the kind of unmet need indicator, but none have really succeeded in coming up with something which is robust and works well in different settings. And even obstetricians at the individual level will often disagree on the situation in which a caesarean is medically necessary or not. So we have this problem. The WHO, as a kind of general rule of thumb, says that they would expect a national caesarean rate to be somewhere between 5 and 15%. That's not based on very much. If you trace back all the references back to the original citation, it's basically a working group meeting of experts in which they just said that. But there is some data from ecological studies. This graph here on the y-axis, you've got the maternal mortality ratio, and on the x-axis, the caesarean section rate. And you can see that when caesarean section rates are very low, mortality is higher, it declines, and then once you get to around 10 to 15% upwards, there's not really any association anymore. And you get a similar picture if you change the y-axis to neonatal mortality, except that the threshold is marginally higher, it's about 15 to 20%. But this is ecological data. There are many other things that could explain this relationship. For example, countries that have very low caesarean rates tend to be different in many other ways. For example, they have a poor health system. So we have this problem in measuring universal health coverage regards to caesareans, in that if we have an overall metric, we don't know how to interpret the number. So as I said at the beginning, the results I'm going to be talking about come from the FemHealth study. FemHealth stands for Fee Exemption for Maternal Health Care. And it was a multidisciplinary, multi-institution study into national policies in Western North Africa, in Francophone countries. Many different countries in the region have introduced user fees, the subsidies or removals policies, and we were looking into the effectiveness of these policies. In this presentation, I'm going to focus on a small subset of the work. First of all, did the implementation of the policy increase utilization? And if it did the policy increase utilization amongst subgroups where there was likely to be an unmet need for emergency obstetric care? So was equity increased as a result of this removal of financial barriers? And I'll be focusing on two countries, Morocco and Benin. Morocco is a lower middle income country. It has a poor but not so poor as other countries in West Africa mortality indicators. And over the period of time I'm going to be talking about, it really has developed very, very rapidly from being a low-income country into a middle-income country. There's been a lot of development. Benin is also in West Africa, is also Francophone, and it's a low-income country. Caesarean rates are much, much lower in Benin, and it's quite a different setting in terms of the need is much greater, and mortality as a consequence is quite higher. So I'll go through each of these in turn. The Moroccan policy focused on both skilled birth attendants and caesarean rates. Benin, the policy was only focused around caesareans, and I'll come to that more later in the presentation. The methods we used for this piece of work, we used two different data sources which were complementary in that they had different strengths and limitations. So first of all, we used routine data, which is collected by the respective ministries of health. The advantage of this data is it's quite easy to get in a timely fashion. It's generally available the subsequent year to the year in question. And depending on the country, you may have some data on complications, which are very difficult for women to report in a survey. The disadvantages is you generally can't disaggregate by socioeconomic indicators or other characteristics of equity, because that kind of information is not included in routine records. So to complement that, we have population-based survey data, which is usually the DHS in these examples. And that has the advantage in the questionnaire. You have an awful lot of information, which is very useful to us. But the disadvantage is that they only take place at kind of intervals of about every 5 years or so. So you kind of have a gap, and they don't always match up time-wise with when you want to, regarding before and after the policy. And the data was analysed using segmented regression, so that we could control for secular trends in the outcome, and we were interested in whether utilisation increased over and above the secular trend. So a bit more detail about Morocco. So in 2008, Morocco introduced a policy to remove all delivery fees for either vaginal or Caesarean deliveries which were taking place in public hospitals. It was only in hospitals, not in health centres. And it was quite a comprehensive package. They removed fees, they removed any other costs for the hospital stay, medicines, examinations, including ultrasound, and if referral transport was needed during the delivery, that was theoretically at least also included in the policy. However, it's a bit misleading if we just look at the effectiveness of this policy as a standalone piece of legislation, because Morocco has actually been the government of Morocco has been very committed over a prolonged period of time to improving maternal and child health, and they'd implemented many other reforms in the run-up to this. So, for example, in the early 90s, they completely reformed the midwifery curriculum. They made it a degree-level qualification and completely overhauled training. There was a 5-year national action plan starting in 1994 to improve services, which involved upgrading facilities, public awareness campaigns, and more training to improve the quality of care provided in facilities. And from 2005, they had implemented mandatory health insurance for formal sector employees, which are the minority in Morocco, but still important. And they'd also started work to implement a fund to provide free health insurance to the poorest households. That hadn't completely been implemented by 2008, and the time the policy we're talking about had introduced, but it kind of started to be rolled out, although not fully. So Morocco had basically been trying very hard, using a lot of different measures for quite a long time, to improve maternal health care. This bar graph just shows you a simple trend plot of what had happened, and it's using the routine data. You'll see, first of all, that there's a steady increase throughout the period, going from 1992 up to 2012, increasing proportion of women delivering within a public health facility. The increase is nearly solely coming from the hospitals, which are shown in green, not from the health centres, which remained fairly static, and that's partly because that was what Morocco was trying to do intentionally in the way it set up its incentives, which is different to some of the other West African countries we were looking at in FemHealth. In a lot of other countries, they tried to get people to deliver in a health centre and then only then refer if they were complicated into a hospital, but Morocco took a bit of a different approach. If we fit a regression model, the overall secular trend is shown in grey at the top. So at the annual increase for around 4% a year, which was statistically significant, so steady throughout the period. And the red dotted lines indicate where there's a break in the model due to the implementation of a different policy. And none of these policies significantly accelerated trends over and above the underlying trend, although that's not in itself surprising, because I think when you look in more detail at the policies, they're all kind of synergistic and reinforcing each other. So I think when we presented these results, the Moroccan government weren't at all disappointed that their fee removal policy hadn't had a significant effect per se, because everything had been so positive underlying that. But what about equity? So the line graph on the right of the slide shows you by relative wealth quintile using survey data, which is a relative wealth quintile. It's basically a measure of your household wealth based on the assets that the household has, what the house is made of, and so on. and there's 5 going from poorest to richest. And it's a relative measure, so we mean relatively wealthier within that country, not rich in absolute terms. So you'll see in the early 90s here, and after the policy in 2010 here. The positive news is that the poorer the quintile, the relatively faster utilization had increased throughout the period. So in relative terms, at least, the equity gap had decreased as a result of the policy. So here, amongst the poorest quintile, utilization of facility delivery was increasing by 9% a year. Amongst the wealthiest, it's 1% a year. So whilst there is still a gap and still further work to be done, the gap had narrowed between the richest and poorest. And in 1991, the relative gap between richest and poorest was 14-fold, so the richest were 14 times more likely to be delivering in a house facility, and by 2010 they were only 2.5 times more likely to do so, which is a really positive trend. So with skilled birth attendants, we do hope to be getting close to 100%, certainly in a setting such as Morocco, where realistically outside a house facility it's very, very difficult to provide skilled quality care. So Morocco's not there yet, but all the trends are looking positive. For caesareans over the same period, you get a similar pattern, increasing throughout the period. We didn't have data for 1992. From what was really quite a low caesarean rate in the early 90s of 1 to 2%, to, and this is just in public hospitals, so the actual caesarean rate is slightly higher, as I'll show you in a minute, to around 8% by 2012. And when a model is fitted, you get very similar results. There's a 10% relative annual increase, but none of the policies in and of themselves significantly increased accelerated trends. However, as I was saying earlier, caesareans are more difficult to interpret because we're not expecting to get to 100%, and we have this problem with both dual over-medicalization and underuse. And you'll see if we break the routine data down by region, it's in Casablanca, which is an urban area. It's where most of the most economically developed part of the country. Caesarean rates are more than double what they are in the rest of the country. They're approaching 30%, which is really, really quite high. So this raises the potential concern that there might be equity issues taking place. And indeed, if we look by relative wealth, in relative terms, the equity gap reduced because the baseline was so low to start with, but in absolute terms, it's increased. So you'll see here, it's a similar graph to before. Amongst the poorest, there is a relative increase of 13% a year, and amongst the richest, a relative increase of 8% a year. But because the baseline is so slow, you end up with quite a large gap in equity. And this is particularly concerning. So the red lines that I've just superimposed, those are showing the WHO 5 and 15% kind of envelope. You'll see amongst both the richest 2 quintiles, caesarean rates are far in excess of that. So the kind of national level figure we're getting is concealing the fact that amongst the poorest, caesarean rates are still very, very low, which is suggesting unmet obstetric need, whereas amongst the wealthiest, caesarean rates are very, very high, which was something we were concerned about. However, if you disaggregate further, so here we're looking by both public and private sector and wealth at the same time, so it's the lowest, poorest wealth quintile through to the richest, with the blue being public sector and the red being private sector. You'll see that amongst the richest, which had that very high caesarean rate, nearly all the caesareans are taking place in the private sector, which are not publicly funded. So the public subsidy isn't being used to subsidise over-medicalisation, which is positive. And in fact, amongst the 4th quintile, they're actually more likely to deliver in a private facility than the wealthiest. So to conclude for Morocco, utilisation has risen substantially, which is very good news. Again, with the overall caesarean rate, 13%, which conceals large equity gaps. But we don't think that the public funding is what's driving that. Moving on to Benin, which we have a lot less data on, unfortunately, because the surveys don't coincide well with our data, with our policy. But in Benin, there was a policy in 2009, and this policy applied in both the private sector and the public sector. It's a fixed reimbursement, so that basically the government will pay for the caesarean regardless of the type of facility, but it doesn't include any other sort of maternal health care, so antenatal care, uncomplicated deliveries, and etc. You still pay. This is caesarean rates by wealth. We don't have much post-policy data, as you'll see, and you'll see that amongst most of the population, caesarean rates are incredibly low in Benin, and even amongst the wealthiest, they're moderate. So what happened when the policy was introduced is using the routine data, which we have up until 2015. There was an annual increase of 2.3% a year, and there was significant acceleration in trends at the implementation of the policy. We do have data on medical indication from the routine data, so it's not particularly reliable, but it's better than nothing in Benin. So this graph is showing us whether the woman had a caesarean, whether she had a complicated delivery that was not managed through caesarean, or whether she had a uncomplicated delivery. And if we break that down into just the complicated cases, darker green being caesarean and lighter green being complicated but vaginally delivered, you'll see that after 2009 there was an increase apparently in the proportion of complicated deliveries being managed by caesarean, which is positive. If you put that into a model, you'll see again there was significant acceleration in complicated deliveries being treated by caesarean after the removal of user fees. But what about mortality, which is what ultimately these policies are trying to address? It's very, very difficult to measure. We don't have good data. We either have data from the survey or data from the routine data, but the routine data only covers the deaths that take place in hospitals. Perinatal mortality was declining prior to the implementation of the policy. In Benin, with the implementation of the policy, that decline continued, but the speed of decline was somewhat slower, but I wouldn't interpret that as saying that the policy harmed perinatal health. It's more that babies that were dying at home are now dying in a facility. They're not counted at home, and they're counted in the facility. And overall, it has wide confidence intervals, but the DHS has shown a decrease in perinatal mortality throughout the period. So to conclude for Benin, Benin is a country with very, very low caesarean rates, and removal of fees did coincide with improvement there, with increasing caesarean rates. And complicated deliveries have been relatively more likely to be treated by caesarean since the policy was implemented. We can't break down by equity now. There's a new DHS in the field this year, so when we get the data, we'll be able to do a similar analysis for Benin. So the implications for measurement of universal health coverage. Universal coverage of skilled birth attendants or facility deliveries alone is not sufficient to avert a large amount of morbidity and mortality. But we have problems in measuring it, especially if we're going to use a composite indicator, as many authors are suggesting at the moment, because even interpreting a single caesarean rate is not straightforward. We don't know what our target is, basically. By disaggregating that subnationally, we can get some kind of nuance about what's happening, but even we still don't have a good way of measuring need for emergency obstetric care. Oh, thank you very much, and just to acknowledge that this was funded by the European Union and some of the other team members.